Hi, very good evening. Hope you're all doing fine. So this live session we shall have few self-assessment questions, right? Also I have incorporated few case-based questions. So we shall have a discussion pertaining to them now for the next 30 to 40 minutes, right? So before that, very good evening all of you. Hope your preparation is going on at full swing. And once again, hi Srish, Preeti, Shivaranjani, Dhanapriya, hi Neetu, hi Rohit, Deepthi, hi Kedar, hi Brijesh, very good evening. Hi Saida. Right. So I'll give you one context first. I'll explain you one case and then we shall have discussion pertaining to treatment related to that case, right? So we shall start with our first one. Hi Akshit, Shruti, a very good evening. So a 12-year-old patient comes to a dental clinic along with her mother because she had some trauma in front part of her mouth. So the patient had no extraoral injuries. There was some injury intraoral where both upper central incisors are mobile and the crowns are palatally displaced. So in such a context, what special tests would you advise for the patient? How would you proceed after clinical examination? So a 12-year-old patient has come to your clinic where the patient had a history of trauma a few days ago. It's not mentioned like how many days, but a few days ago there was some history of trauma where there was intraoral injury where the two upper central incisors are mobile on clinical examination and they are palatally displaced, right? There are no extraoral injuries, however. So in such a case, how would you proceed further? What special tests would you advise to the patient? And also why? How do you justify those tests? Hi Sirisha, Ali, Shipra, hi. So you want to go for direct splinting there? Okay, right. So we'll go one by one. Yes, as you all have been rightly mentioning. So in cases of trauma, the moment patient comes, depending, first you said radiographs or vitality tests, right? Good. So we'll just go. So in cases of trauma, yes, obviously after intraoral examination, you'll go for vitality test. Good. And also, as you rightly mentioned, we also go for radiographs. A periapical radiograph, intraoral periapical radiograph, isn't it? So, as few of you have answered that we shouldn't go for vitality test. It's not about vitality test which is contraindicated. Maybe if the history of trauma is few days ago, maybe we will not go for electrical pulse testing. But we have various other vitality tests like heat test, cold test, isn't it? So we have to go for vitality tests in order to evaluate the status of all the teeth because there was a history of trauma. And then obviously we go for a radiograph. So why do we need a radiograph? Yes, as you know, in cases of recent history of trauma, there can be stunned pulp. Pulp is in a state of physiological arrest, so we can't elicit any response with the repeat. So obviously we need to go for vitality tests, other vitality tests and also radiographs so that we can rule out any fractures, isn't it? So that's a common sense. So we obviously go for vitality tests and periapical radiograph and if necessary even an occlusal radiograph, upper occlusal radiograph. That's fine, good, well answered. Now a continuation question for that. If on radiographic examination, so you have taken an IOP, So on radiographic examination, there is fracture in the middle part of the root. So in the mid-root area, there is fracture of the root in case of both central incisors. In such a case, what treatment would you proceed with? Yes, Prishanti, Rohit, Shivaranjani, Nandini. Hi Niharika, very good evening. Hi Nandini, Prishanti, hi. Hi Bernice. Yes. So how would you proceed? What kind of treatment would you suggest? Is it root canal the priority or is it splinting? So which one do you think is a priority? Would you like to go for extraction, Bernice? Okay, Saida says RCT and splinting. Kinjal, hi, good evening. See, it can be either oral surgical part or it can be endodontic part, no matter what it is. Whenever there is fracture, what should be the primary objective? As we have discussed in previous live session also, immobilization should be our primary objective. Then after immobilization, right, after splinting and all, you can go for definitive treatments like root canal treatments or surgeries or whatever which is required based on the clinical scenario, right? So we go for splinting. Very good. In case of, now the question is, so obviously we go for, so in the treatment part, we're talking about splinting. Since there is only fracture of your tooth, but not your bones or alveolar process, what kind of splinting would you advise in that particular patient? So if you remember, we have rigid splinting, flexible splinting and all, right? So what kind of splinting is advised and why? Good. So obviously, as Alankrita said, non-rigid in the sense you mean flexible splinting? Yes, Akshay, good. We have to stabilize the tooth first. Yes, the time period is perfect, so we go for flexible splinting, right? Flexible splinting for a duration of 2 to 3 weeks, beyond which there can be again ankylosis and all. Fine. So why do we go for flexible splinting? Why not rigid splinting? In other words, what are the advantages of flexible splinting over rigid splinting? Hi Bipin, very good evening. Yes, Angel, fracture in middle third has poor prognosis. That's true. But the prognosis is worse in case of your kernel third fracture. So obviously you can go for, imagine you're dealing with the aesthetic zone in case of a 12-year-old patient. So would you directly advise extraction? So when you have an option to say, why don't you try? Good, Mayor. So how do you justify that? You said healthy blood supply and flexible splinting. So how would you justify your statement? So flexible splinting is that splinting which would allow the physiological movement of tooth. So this would allow physiological movement and there are lesser chances of ankylosis, right? So we advise flexible splinting. Now, the time period or duration is also equally important, 2 to 3 weeks, as per various literature or various articles mentioned. Now, the question is, so far we are continuing with the treatment part. Now, what if the kernel portion, so that's the next statement is, so once you have done this splinting, 2 to 3 weeks, perfectly fine. So we could achieve some amount of immobilization, but after which you found out that the kernel portion of the tooth, kernel in the sense, kernel to the root fracture. So the root has fractured in middle third, so the kernel segment of the tooth has become non-vital. So how would you proceed in that case? What if the kernel portion of your fractured tooth segment has become non-vital? how would you proceed in such a case? What would be your treatment? Yes, 10 to 14 days, 2 to 3 weeks, depends on the literature which you are referring. Yes. Kernel is a segment in the sense we're not just talking about the crown, even the root part, which is kernel to the fracture, right? Yeah. So the pulp, which is kernel to the fracture site, has to be extirpated, and then we go for placement of calcium hydroxide and see that there is barrier formation kernel to the fractured segment. Once the barrier is formed, so barrier formation is seen with calcium hydroxide. So calcium hydroxide has to be changed for every 3 months with follow-up. And finally, once the barrier has been formed, a calcific bridge is formed, kernel to the fractured side, then you go for gutta percha filling, right? So eventually you complete your root canal treatment, right? And then followed by root canal treatment. So all this is fine. Now, after proceeding with root canal treatment, the tooth has to be kept under observation. Now, if there were no fractures, so far we have seen that if there were fractures, we would proceed in this way, right? Splinting followed by root canal. What if there are no fractures? So the patient has come, you have done vitality test, you have taken radiograph, there are no fractures. So how would you manage in such a case? There are no fractures. Yes, Preeti, pulpectomy or root canal treatment, apical segment is not required. So that's the reason why we said after completing root canal, we review and follow up. Because once the tooth is fractured in the middle, that it will be challenging for us to proceed to the apical segment. Good. As all of you rightly mentioned, we go for a splinting. So there is no fracture. So why do you want to go for splinting in this case? So previously we thought that on radiographic examination there is fracture, so we have gone for splinting. But now I'm saying there is no fracture on observing the radiograph. So why do you want to go for splinting? Good, Akshit. Exactly, that's the point, Angel. Very good. So we have a case of palatally displaced tooth. As I have explained you the case in the beginning of this video, I said the tooth is mobile and it is palatally displaced. It means it comes under Ellis. Which classification does it fall under? Which class of Ellis classification does this fall under? Very good. Yes. Perfect. Akshat, Mer, Preeti, Brijesh, Neetu, Shivaranjani, Srish, you're right on target. Good. Yes, Saida. So let's have a brief summary or discussion of all Ellis classifications, right? Different classes of fractures. Ellis classification for fracture of anterior teeth. So class 1, fracture of only. Hi Farheen, a very good evening. Farheen, I'm not ignoring you in this live session, right? Yeah. So yes, so Ellis class 1 is only fracture of enamel, Ellis class 2, enamel and dentin. So class 3. So Ellis class 3 falls under like, yeah. Yes. Ellis class 3 involvement of pulp, Ellis class 4 a non-vital tooth, Ellis class 5 loss of tooth or avulsion, Ellis class 6 root fracture with or without involvement of crown, class 7 displacement of tooth, subluxation, palatal, labial, mesial, distal, displacement of tooth, Ellis class 7. Yes, class 8 is, yeah, class 8 fracture of tooth, crown and mass. Class 9, involvement of your deciduous tooth, fracture of your deciduous tooth. No, this Ellis classification is for anterior teeth. Yes, people? Right. So that's a brief summary of the Ellis classification as well. Now, a continuation question for the same case-based question. If a dentalular fracture had been diagnosed, so till now we have assumed that there could be fracture of root or nothing. What if there is dentoalveolar fracture? How would you manage that case? Or how would your management be different from what you have discussed previously? Very good, Niharika, Bernice, Tabish, Alankrita. Yes, Neetu, Shivaranjini, Farheen, Bipin. Yes, we go for rigid splinting in cases where there is dentalular fracture or fracture of the alveolar process, and at least for a duration of 3 to 4 weeks. I hope you can see if I write down here, right? So dentoalveolar fractures. So rigid splinting, duration of 3 to 4 weeks. Okay. Fine. So this is one case-based question which I wanted to discuss. Usually we have these kind of questions in ADC exam, or even in our COMET previously we used to have these kind of formats. Maybe you can expect the same. So one case-based question, you will have a lot of stuff to learn from this, right? So this is in brief about how you manage a case of fracture, right? So depending upon the fracture extent, depending upon the condition of tooth, and also depends upon the status of the periodontal or the surrounding tissues, right? So I hope it's clear. We'll move on to the next question. Yeah. Now, we have another patient, a 15-year-old patient. So this is the second case-based question. A 15-year-old patient who complains of a mobile upper tooth. So that's the chief complaint, mobile upper tooth. Yeah, hypervel. So examination reveals that the tooth is a deciduous upper left canine. So on examination, upper left deciduous canine is mobile, and the permanent canine is not visible clinically. So how would you determine whether there is an unerected permanent canine? So how would you know whether you have a canine or not, a permanent canine or not? So clinically, how do you, or what tests, or how would you check for the presence of a permanent canine which is not visible clinically, in fact? So obviously we go for radiographs. Good. So radiographs, fine. We can based on radiographic appearance, we can say whether we have a permanent canine developed or not. How would you know the presence of a permanent canine clinically, even though it has not erupted? Yes, one is age. So on clinical examination, there is no permanent canine eruption in the tooth, in the oral cavity. But how can you assess the presence of a canine based on the position of various other teeth? I hope you got my question right. So based on intraoral examination, how would you assess the presence of a permanent canine? Very good. So that's what I was expecting. Hindu, good. Diastema, ugly duckling stays. Exactly. Displacement of canines, displacement of central vernus. Good. So you see, patient is 15 years. We don't expect ugly duckling stays now, right? 9 to 11 years, ugly duckling stays. Fine. The lateral incisors, if they are appearing to be protruded, it means there is a canine, a developing canine deep inside, which is placed buccally as a result of buccal placement of unerupted permanent canine, it is impinging or displacing the roots of lateral incisors palatally. As a result, the labial surface seems to be proclined. I hope it's clear, right? So the protrusion of lateral incisors would clinically give you a hint that there is a buccally positioned canine, because a buccally positioned permanent canine would impinge upon the roots of lateral incisors in palatal direction. As a result, the lateral incisor seems to be slightly protruded clinically. So that's one clinical clue based on which you can say that you have a buccally positioned canine. That's fine. And what other measures, by taking what other measures can you find out the presence of a permanent canine except for the clinical appearance of a lateral incisor? So radiographs is one way through which we detect. That's absolutely fine. So another aspect is, as you said, ugly duckling stays depending upon the age or the position of lateral incisors, as we have discussed now. So what other measures can you take in order to find out the presence of a canine? Model analysis. Okay. Palpation. By palpating in the sulcus, if at all there is a developing tooth inside, you can feel the bulge because of this unerupted permanent canine. So, through positioning of your lateral incisors, through palpation and also through radiographs. So, these are the various methods through which you can identify the presence of a canine, isn't it? Yes. Yes, also resorption of deciduous canine root. Obviously, deciduous teeth will be in a state of resorption. That's true. If at all there is a succedanious teeth or tooth, there can be resorption, right? So, the point here is unerupted permanent canines can be evaluated, as you all said, through radiographs, position of lateral incisors, and based on palpation. Now, yes, also as Angel said, resorption of, the patient complains of mobile deciduous tooth on extraction or on removing it based on the surface integrity of the root. Yes, we can to some extent, fine. Now, the question is, if at all you are advising a radiograph, what radiographs would you prescribe to that patient? Yes, OPG. Occlusal radiographs, yes, and also IOPA, right? Even an intraoral periapical radiograph. So panoramic radiograph, OPG, or it can be IOPA, or even an occlusal radiograph, isn't it? So the question here is, if you have, for example, you have a panoramic radiograph and an IOPA, you have two radiographs pertaining to that patient. One is OPG and the other one is IOPA with in respect to the second quadrant, that is canine. So in such a case, how would you determine the exact position of an unerupted canine? So based on your panoramic radiograph, based on your IOPA, so you have only two radiographs here, you don't have occlusal, right? So if you have occlusal radiograph, you can say whether the tooth is present buccally or palatally, that's fine. You have only panoramic radiograph and IOPA, so based on these two, how would you determine the exact position of an unerupted tooth? That is your canine in this case. I know you would answer that as slop technique, that's absolutely right. But slop technique is something which is done in horizontal plane, isn't it? So tube shift technique or slop technique, where you move the tube from one position to either mesial position or distal position, isn't it? So same side lingual, opposite side buccal, I'm sure you're all confident and thorough with the concept. But what if, but here I've given you only two options. You have only panoramic radiograph and you have an IOPA. So what is the difference between the two in terms of angulation, in terms of vertical angulation? What is the difference between these two radiographs? I didn't say you have two IOPAs with two different horizontal angulations. I said you have one IOPA and one panoramic radiograph with same horizontal angulation. Yes, Niharika. See, IOPA, the vertical angulation would be 45, 15, 20, 30, 35, 40. What would be the vertical angulation for IOPA in case of canines? I think it's 45 degrees, right? I'm talking about maxillary canine. Exactly. So that's my point. So in case of your OPG, you don't give any vertical angulation, but in case of your IOPA, we do give a plus 45 degree vertical angulation. So there is a difference in vertical angulations, but not horizontal angulation. So in such a case, how would you bring out slope technique here? Slope is something which we are dealing with in horizontal, right? Isn't it? So how would you decide the position of a canine based on panoramic radiograph and based on IOPAs? That's my question again. So how would you explain or how would you answer my question now? This slope technique is not just in horizontal direction, but slope technique can also be applied in vertical direction. So would anyone explain this to me? Because horizontal slope technique, you're all very familiar, right? But how would you decide the position of an object based on different vertical angulations? So that's the question which I want to leave unanswered, right? So in fact, I have a diagrammatic representation. I've got a diagrammatic representation, but I want you to think and I want you to answer, right? So we should have a discussion pertaining to the same. It's not clear, right? It's in highlighted marker. I used highlighted marker there. Fine. So we shall have a discussion pertaining to the same tomorrow. I'll give you time till tomorrow. So let me know, or you can explain on a piece of paper and take a pic and share in our group. It doesn't matter. How would you explain the same slope technique in vertical direction? I hope you got my question right. It can be any other tooth, Abhishek. It's not just canine, right? It can be any other tooth. Yes, Bernice, depends on the position of the tooth, right? Anyways, you just think over it. We shall have a discussion pertaining to the same tomorrow. Yes, Alankrita, Walton's projection, it has something to do with your endo. I mean, in order to identify your double canals, double rooted teeth, in order to differentiate between two canals, you have this Walton's projection, right? Yeah. Fine. And as a continuation part of the case which we have been discussing, so as you rightly mentioned, we can use slop technique, right? We can take two radiographs in different horizontal directions, or we can even take an occlusal radiograph in order to identify the position of a tooth, buccally or palatally, right? Yeah. Yes, Abhishek, just go through. You just put on paper. You just compare the slop technique, which you already know, to that of in vertical orientation. It will be much more clear, right? Just give me 1 second. Okay. Now, final question pertaining to the same case. What single radiograph could be taken to determine whether the canine is placed buccally or palatally? Only a single radiograph, which would help you to determine the position of this unerupted canine, buccally or palatally. Yes. So obviously we go for occlusal radiograph, isn't it? So occlusal radiograph would help you to determine the position of a tooth, either buccal or palatal. Fantastic. Now let's move on to the next question, next case-based question or next set of questions. I'll give you the names of few appliances. Tell me which kind of appliance that particular appliance which I tell belong to. Anderson appliance, Frankel appliance, twin block appliance. So what or in which category do you place these appliances under? Anderson, Frankel or twin block appliance? Good. So we categorize these appliances as functional appliances, right? Myofunctional or functional appliances. So how would these functional appliances work? So what is the principle behind working of these functional appliances? Why do you call them functional appliances? So a functional appliance is called as a functional or myofunctional appliance because it uses or guides or eliminates the forces which are being created by your oromusculature or in the process of tooth eruption or during the process of facial development. So those forces which are being generated during various functional movements are either being used or guided or eliminated in order to prevent or treat cases of malocclusion, isn't it? So they activate through functional forces. So various forces which are being created by your oromusculature, tooth eruption, or even during the process of the growth. We have this growth spurts and all, isn't it? So all these appliances fall under the category of functional appliances. Now, which age group of patients are they most effective in? So in which age group of patients would we advise these functional appliances? So this has something to do with the growth spurts. So when do you find these growth spurts in case of males or in case of boys or in case of girls? Fantastic. So in case of girls, nine to 11 years, 9 to 10 years maybe. In case of boys, 11 to 12 years. You can make this 10, right? So these appliances are advised in patients where we don't find these growth spurts. In the sense, before the growth spurt is seen, so that we can make maximum use of these growth spurts to harness the energy or forces which are being generated to treat various malocclusions, right? So growing children, preferably before the pubertal growth spurts. So these are the ideal conditions where we can advise this functional appliances, right? So what age group of patients are the most effective in? So in case of growing children, before pubertal growth spurts. In case of girls, it is 9 to 11 years, boys 11 to 12 years, right? So what conditions can be treated, or what type of malocclusions can be successfully treated using these functional appliances? So usually, on an average in boys, the growth spurt is seen 2 years late compared to girls. So in case of girls, it's 9 to 10. In case of boys, it's 11 to 12 years, approximate. So what kind of malocclusions can be treated using these functional appliances? I hope you can see it here, right? Yeah. Okay, let me just write down here. Mostly class 2 division 1 open bite cases and even class 3 malocclusions, right? So these are the malocclusions which can be treated effectively. And what skeletal changes do these functional appliances bring? So what kind of skeletal changes can we anticipate with respect to maxilla and mandible using these functional appliances? Yes, so restriction of maxillary growth, forward maxillary growth is restricted, and also mandible is stimulated to grow forward. So these are the anticipated skeletal changes using these functional appliances. In fact, it's mentioned that mandible is stimulated to grow in the glenoid fossa, and it acts by pulling the condylar cartilage forwards. So the condylar cartilage is pulled forwards using these appliances. Right, good. Now the final continuation question of the same. What are the various skeletal and dental changes you see using these functional appliances apart from what we have discussed here? What are the various skeletal and dental changes which we can expect using these functional appliances? So these two come under skeletal changes, right? So I'll just write down in brackets. Skeletal changes include restriction or restraint of forward maxillary growth, optimization of mandibular growth, optimization, forward movement of glenoid fossa, and increased lower facial height. So these are some of the skeletal changes which we can anticipate, right? And coming to dental changes, lingual or palatal tipping of maxillary incisors, labial tipping of mandibular incisors, inhibition of forward movement of maxillary molars, and mesial and vertical eruption of mandibular molars. I'll just make a note of them. So dental changes. Palatal tipping of maxillary incisors, labial tipping of mandibular incisors, right? Yeah. Along with that, yes, as you mentioned, prevents the mesialization or inhibition of forward movement of maxillary molars. There is distalization of maxillary molars and mesial vertical eruption of mandibular molars. Fine, I hope you can see. So these are some of the dental changes, right? Okay. Right, so it's been 45 minutes. I still have few SAQs to be discussed. We shall do that later, right? So we'll not extend the session for more than 40-45 minutes. So it's already 45 minutes, right? So we'll just have a brief summary of all that we have discussed so far, and then we shall conclude this session. We shall discuss the other SAQs tomorrow, right? So as we have been discussing so far, so first there is a case-based question on the trauma case, right? So whenever there is any trauma, you go for vitality test or radiographs. Depending upon the extent of fracture and location of fracture, the treatment procedure continues. And here we have discussed about splinting. So in case of only dental fractures, we go for flexible splinting, which allows physiological movement of tooth, and the duration is 2 to 3 weeks. In case of dentoalveolar fractures, we have to go for rigid splinting for 3 to 4 weeks duration. And root canal treatment, the protocol we discussed with calcium hydroxide therapy, barrier formation, and then followed by gutta percha obturation and review, right? And then we have also seen regarding assessing an unerected permanent canine clinically and also radiographically. So clinically we can either go for palpation method, and also based on the position of other teeth, we can expect or anticipate the position of your canines, permanent canines. And based on radiographs, we have gone through slope technique. So slope is not something which is oriented or which is assessed in horizontal direction, but also can be assessed in vertical direction. So we have a panoramic radiograph, that is OPG, with 0 vertical angulation, and a IOPA with maximum 45 degrees vertical angulation in relation to canine. So based on these two radiographs, how would you apply slope rule there in order to evaluate the position of an unerected canine, either buccal or palatal? So that's the question which I haven't answered, so we should have a discussion pertaining to the same tomorrow. In the meantime, try solving it, right? Put it on paper and see if you can shed in group. And also we discussed about various functional appliances, the rationale or the principle behind the working of these appliances. They utilize the forces which are being generated by the orofacial musculature, the eruption forces of your tooth, or it can be either your growth, right? The growth of your face. And also, these are particularly advocated in case of growing children before we find pubertal growth spurts. In case of girls, it is 9 to 10. In case of boys, it's 2 years on an average rate, that is 11 to 12 years, right? And finally, we have also gone through the cases where these functional appliances can be indicated. Class 2, Division 1, in cases of open bite, even in cases of mandibular prognathism, right? And various skeletal and dental changes, as you have seen. So restriction of maxillary growth promotes condylar cartilage movement forward, thereby optimizing the mandibular growth, and also increases lower facial height and forward movement of glenoid fossa corresponding to the condylar cartilage, right? And various dental changes include palatal tipping of your maxillary incisors, labial tipping of mandibular incisors, and discalization of maxillary molars, or prevents the mesial migration or movement of the maxillary molars, and promotes vertical mesial eruption of mandibular molars, right? So these are various effects of your functional appliances in brief, right? So we still have a few more SAQs. Should not extend this session further, right? So we'll stop it here. So if you have any further questions, drop a mail, and I hope your preparation is going on fine, right? So you still have a couple of days, around 10 days, and I hope you'll all excel in your preparation. So this is a time where you need to be more focused, keeping the distractions at bay, right? So don't get frightened or don't be worried. The only thing that has to be there in your mind is giving your best. The rest of the things are not in your hands, just leave them. You still have time for them at a later date, right? So wish you all the best. Love you all. Yes, Niharika, slop technique. When you move the tube towards the same side, if the object is moving towards the same side, it is present on lingual. If it is moving in the opposite direction to the movement of your tube, it is in buccal. You can refer our E-classes radiology section where I have given you a few illustrations also drawn on a piece of paper, and I have put those illustrations in our E-classes. You can refer that for more clarity, right? Angel, rigid, non-rigid splinting. So we have different splint materials available depending upon the material with which it is made. For example, if it's made of fiber material, we have this flexible splints made of fiber, or we can even use a wire, an orthodontic wire for rigid splinting. So we have different materials that are available, right? And also we have shared, I think we shared the picture of fiber post. Okay, in image-based questions, if possible, I'll discuss these fiber materials also. Yes, for him, we're not talking about primary teeth here, we're talking about permanent teeth. Splinting is not indicated in case of your primary teeth, right? So all this which we have been discussing here, it's related to a case where there is a trauma in relation to 1-1 and 2-1. Okay, fine. So we'll start with slop rule tomorrow, right? And again, we'll proceed with the next set of SAQs, if possible, few MCQs, and also image-based questions, right? Yeah. Yes, so I'll be sharing the same notes in your Google group also. So you can store them and you can refer them at a later date just before exam as your final review notes, right? So I hope you got some clarity pertaining to few concepts and also few important take-home points from this live session, right? So I wish you all the best and see you all tomorrow. Yeah. Yes, Bernice, we're missing Regina again. So see you all tomorrow evening at 8 p.m. right? Yeah, bye. Love you all. Take care. Yeah, by the way, I wanted to ask you this. How is live session today in terms of visual perception. Is it clear comparatively? Do you find any improvement? I want your feedback because I've changed a bit of setting here. I have huge lights behind the cam. So how is it? Do you think it's fine, improved, or do you still find some amount of haziness or shadowing on the board? Yes, we tried to eliminate the reflection from board, so that we could successfully do it. But still, there is some amount of reflection here. I think this is negligible, right? Yeah, only in this particular area we have some reflection which is negligible. So it's clear? Good. Okay, Kedar, you're welcome. Thank you. Thank you for your wonderful wishes. And I said, this is not just my achievement, this is our achievement. This couldn't have been possible without this kind of reciprocation, as I keep on saying. So this is our award and this is our victory, right? Yeah. So I'm glad that we're all part of this and we all join on this common platform, and I hope you're enjoying this entire process. Yeah. See you again tomorrow. Bye. Take care. Yeah, yes, Preeti, I can understand because the previous one we used to use this white light, but now it's yellow filter. Okay. Right. Good night. Bye.